Yeah, so we can do a little comparing and contrasting between the two activities. So as you pointed out, with TaraVista, it was a total greenfield, build it from the ground up, purchased the land, hired an architect. I've got a builder partner, GFI Partners, who constructed the building and has been with us there at every step of the way. We had just a longer lead time, and we could start that design process from the ground up, starting as we do everything with the patients. What are their needs, needs of their families, quickly moving into the needs of our employees, of our care team members who provide this care. And we were able to do things like have patient user groups and have user groups that use every part of the building from the kitchen through to the clinical areas, and a long lead time, or longer lead time than we have here. Contrast that with Mira Vista, our sister facility, if you will, about an hour and a half away, where we're inheriting a building with some pluses and minuses. The plus is that we're going from, as I said, closing on the building and beginning our hire process to admitting patients is going to be about a 9 or 10 weeks from the time we closed on this second part of this transaction. This is called an asset purchase agreement. We've been able to, the building is already safe for, it had psychiatric services in it before we assumed ownership. Those services had closed about a year ago. And the good news is that unlike building from scratch, takes 18 months at the very fastest, which is what we were able to do. This is an existing building that really needed a refresh more than anything else. So we're refreshing the inpatient services. We're refreshing the exterior of the building so it has a different look and feel. There's another advantage in spite of this quick time frame, and that is that we're able to hire staff who had worked in the building before we took over. And so we have people who are familiar with the space. They're familiar healthcare providers. They've already provided inpatient psychiatric services and addiction services. So we start with a head start in terms of our hiring. We've already hired 100 or so professionals. And that's a much faster pace than we went with at TaraVista.
Okay. And as I understand it, you're staggering the services that you're providing as the entire building comes into use, and as you introduce your service line, there are certain priorities initially, and then other service lines will be added later. Is that correct?
That's exactly right. And the most important bit of continuity that we had to have without a moment's interruption is that we have an opioid treatment program that has existed here at what was then called Providence Behavioral Health, now Mira Vista. That service is perhaps one of the oldest ones in the Commonwealth of Massachusetts, serves about 700 patients daily. And we really had to have no interruption in the provision, in this case of methadone, for those patients. So we really, night before on a Tuesday night, we're helping the prior owner of the facility and of that service close up, and we had to be ready to open at 5 o'clock the next morning, and there can be no delay. It has to be seamless for those care of those patients, and it was pulled off without a hitch. So in terms of the staggering of services that we'll provide, that methadone maintenance clinic is the one that we started with, a panel of about 700 patients, as I said. The prior owner had also had a 30-bed inpatient detox center and a 27-bed step-down service, as well as some outpatient services. Those services, we call it, will have a momentary disruption. They discharged each of the patients who received care under the prior owner. We will re-stand up those services relatively soon. But the real focus from the Commonwealth is on reopening, or in this case, opening these psychiatric beds. So we've been very focused on getting 36 beds operational with the capacity to start admitting patients tomorrow. So in that kind of service range, we have those 36 beds, which are adults. Will create some additional adult inpatient capacity. The Commonwealth suffers the most around providing services for children and adolescents. Those young people wait in emergency rooms, sometimes really extraordinarily long lengths of time, burden for them, for their caretakers, their parents, their family, and for the emergency rooms that are working to care for those patients. So we'll be working to stand up from 12 to 16 beds to serve that population as fast as possible. It's a little more challenging to provide services for children and adolescents. It's tougher to find the medical providers, and it's a little bit tougher to find nurses, mental health workers who feel comfortable working with that population. So that'll take us a bit longer, but we're committed to the community, and we're committed to the Commonwealth of Massachusetts to stand up those beds sometime during the summer. In total, we will have between 74 and 84 inpatient psychiatric beds spanning the age range, and we'll have 30 detox beds, 27 step-down beds as they're called, and then this pretty robust opioid treatment program that is the one service already underway. It's a great question, David, and as I'm a psychologist by training and still by practice, I'll just sort of insert, every story has decisions about when you leap in to start to tell that story, right? Any story.
Sure.
And in some ways, the story of TaraVista coming into being, I'm reminded by one of our departmental health regulators that it was over 25 years ago that I first spoke to her. I'd forgotten this conversation completely. That I'd spoken to her, we were in different positions at that time, of this dream of starting a hospital from scratch, of what it would be like to not really inherit the culture of a different place, or necessarily the staff and the way they'd operated throughout time, but instead gather together ideas about both design, in case of what we're able to do at TaraVista in building a building, but more important than the building by far is the people, how to have them come together, be inspired, I hope, by a particular story, by an aspiration of the kind of care that we're going to provide. And so while you could say the genesis of it is over 25 years ago, in realistic terms, more kind of proximal to when we opened the facility, I worked for about a year on a business plan that I described to people as being like a novelist working on a novel that had a very low chance it would ever see publication, it would ever see the light of day. I worked on this around the edges of my pretty full-time work that I had through Health Partners New England, and solicited the input from a number of experts, worked on the financials, worked on a kind of clinical model, a description of what it was that I was trying to do. And fortunately found, once that business plan was done, I was reached out to a builder that I knew and an investor, and I really didn't think he would necessarily be interested in investing directly, but just said, how do you think we could get this funded? And then it turns out he was very interested in doing it. So I'd say there was a solid year of a lot of work on that business plan before getting to the funding stage. Once we got to the funding stage, it was 18 months to complete the building, and that 18 months we're able to use for making decisions like selecting an electronic health record, for example, and all of the vendors, and just many hundreds and I'm sure 1,000 decisions, as well as then starting to hire and getting people ready to admit our first patients, which occurred in November of 2016. So at its simplest, I determined that to claim to create a state-of-the-art healthcare facility, behavioral healthcare facility in my case, without an electronic health record, really certainly didn't suggest that it was at all state-of-the-art. To be on paper and pencil in this day and age just seemed it would not be a premise that would have face value if I said it was really state-of-the-art. So, but even having said that, that doesn't mean it was an easy decision. It's spending money that's going to be scarce. Capital is scarce, and it took a leap of faith to decide here's the place that we were going to spend money on, both the I'd call it the kind of pure IT side, and then as well as the electronic health record itself side. So again, kind of the premise was it's hard to say that it's state of the art. That was the kind of first place I started. The second experience that I drew on both directly and then just really more than anything talking with other colleagues is how the additional challenges, if you will, of a conversion. Though I would assume many in your audience today are considering a conversion from paper and pencil to electronic health records, something I still mightily and heartily recommend. But I really felt like we had a one-time opportunity as a startup to say, well, let's come right out of the gate with a system in place, as opposed to getting launched and then kind of in a certain way having to go backwards to now implement an electronic health record. And that premise was supported by talking with my colleagues who were doing installations of various systems. It was really that idea, and then the advantage of an electronic health record, as I suspected there would be, and as emerged to be true, for care collaboration, really added to my decision making. And then there was a process. I mean, I'll pause before going to that, just see if you have other questions about what I said so far. But we then, I set up a pretty structured process that helped us determine which system that we would choose and then work to implement. Yeah, so David, I did start with some of these in mind, and I'll lay out at least my recollection of what I started with, and then I got educated. I became educated as we went down the path of what various systems had within them and what they didn't have within them in terms of my own criteria. So in no particular order, because I haven't really thought it through about which of these were the most important things, but I really wanted a system. First of all, it had to have a history. I was not in I was a startup. I couldn't risk us not getting to the finish line by choosing a partner or a platform that was too new. So I really among the criteria, I wanted something that could show an experience base, and the product that we selected, which we'll talk about, had actually an extremely deep experience base that had been used within the VA for many years. On the VA side, what we use CareView is a commercialized version of Vista. So that was one criteria. It had to have an experience base. We could not be a test case. And I did have a lot of places reach out to me once it became public that were starting this hospital, including startups that said, "We'll do this. We'll be your partner. We'll evolve together." And I really decided against that over time. The other piece is that I really needed it to be integrated already with a revenue cycle product and with an accounting system. I knew enough to know that you just didn't want these things to be divided up in their own buckets and not speak to one another. So I has a criteria that they should talk to each other, if you will, so that it was really a fully integrated system from revenue cycle, patient registration, revenue cycle, through the care provided within the inpatient unit in my case, and then the accounting system that was kind of keeping score about all of that stuff. So the initial criteria included that. The other piece was expense. Folks know the company Epic, and I mention them because they're kind of easy to mention. They're so big, they're so expensive. I didn't have to do any investigating. I knew really already that they were so large that they would not be a logical choice for us. But they're an example of a system that I know places are happy with once they've implemented, but enormously expensive. Just not even close to what a standalone behavioral health facility could consider. So expense was really important. And then just to note that expense, we usually think in terms of money, which is true, and certainly labor translates to money. But I also knew that I had one shot to get this implemented and have our staff have a level of satisfaction with it. And a misstep would be costly, not only financially, but it would be costly in terms of credibility with our staff and this emerging hospital. So I was, to the extent I could, trying to make the right bet with what partner and what platform would work to accomplish each of those pieces. It's absolutely right. And by the way, just sort of going backwards in the story, the first resource that I retained actually was IT. Among the very first on the operational side, you know, we obviously retained my partner on the construction side, retained all the contractors and the subs and do all that sort of build the building. But the very first person that I hired, a group, it was an outside group that I hired, was an IT group. And the idea was I'm so naive about it that I needed somebody sitting alongside me to now look out onto the field to make every decision that had to do with IT. So I say if it involved pixels or electrons, I wanted this group to be sitting with me to help make decisions. And while they did not make a decision about our selection of a electronic healthcare electronic healthcare record, they were with me as I was making that decision, as I was vetting each of the possible candidates for.
So a wise man knows what he doesn't know.
That's all right, and I don't know a lot. I still don't know a lot, and I certainly knew that I needed a lot of help about this one. So, but your point is right. Before we'd hired any staff, we were already along the path of making this selection. What I did do, of course, logical to do, is I called other hospital colleagues and asked, what are you using? What do you recommend? How's it going in terms of implementation? And a number of systems were ones that I rejected. We still reviewed them, we still entertained them, but when I heard about how they were going on the ground and how expensive they were, I rejected a number of them based on user reports about what they're like. And again, ironically, I found Medsphere, I found CareView, not directly, but I found them because there were clinicians who had practiced in the VA, and they described the system named Vista, and called Vista, and they said that they liked it, that once they kind of got used to it, they learned it, that it was they recommended it, and this person, a couple of these folks who work in the VA, didn't know that it existed in this other version of CareView, but it's what got them into the mix in terms of the systems that I was reviewing.
It sounds like, based on your experience, we have to ramp up our marketing efforts a bit.
Well, that was 5 years ago, 6 years ago when I first found you. So it's
and we have since then.
Yeah, that it's an awful lot. You folks have many more installations compared to when we started with you, and I'm sure you are much better known now than 6 years ago. And also, I've got to say, it was my naivete too. It could be that you were very well known. I was just in the very beginning of researching what would be the best system to bring in. I also just want to sort of just note, and not all practitioners were eagerly embracing this, and I don't think that it's reasonable to expect in any either greenfield new hospital starting and they choose this system or any other system from the beginning before they even launch, or retroactively, which is obviously going to be the vast majority of cases, installing an electronic health record. I think it's reasonable to expect that not all practitioners are going to embrace it with equal zeal. They're somewhat correlated with age. Folks who were trained without using electronic health record at all are going to have a harder time if they're not savvy about typing. I mean, for example, although there's methods of doing verbal descriptions of your care and then having it translate into electronic health record. But folks who've really grown up with all manner of electronic products are going to be much more comfortable versus folks as old as I am who didn't start out in their career with this, right? We started out with paper and pencil. However, I'd say once implemented, I doubt there are any practitioners that would ever want to go backwards. I don't know that with certainty, but I think once one sees the robustness of what can be done with an electronic health record, it's just hard to imagine you'd ever want to go backwards. Yeah, the great question. Well, first of all, that word culture is something that I talk about a lot. I contemplated when I wrote this business plan as I began speaking with user groups right from the beginning of creating TaraVista and then MiraVista, because I think of it as our secret sauce, that is true of all organizations. There are those that can provide the same food, a service industry, an airline. We just look at all the things that we all consume, and there's great variation in terms of the culture of different companies and the look and feel, and I would argue, and others would argue, and their ultimate success. So really focused on that culture from the beginning. With regard to the electronic health record, it was as I said earlier, one part of it was we wanted to be state of the art, and being on paper just wasn't going to be that. The other is just the improvement in care provided, the reduction of errors, the greater ease of being able to do electronic ordering of a lab, of a pharmacy, of being able to read results from the lab, of having the care team be able to all look in on a chart together. If not at the same, they can do it at the same time. They could be in different parts of the hospital. It could be at home looking at the electronic health record, or sitting together. And just what a great tool that is, and compared to a paper chart that has to be passed around, that you've got to go find who's got the chart, etc. And then I'd also just note, not usually so obvious, but the coding of the bill of the electronic health record before it's sent out as a bill, also greatly enabled by, facilitated by having electronic health record in a way that's just not possible if it's a paper chart. And you've got the tradition of a paper chart down in medical records and a series of coders that unpack that chart and then reassemble it and do the coding. All of that able to be done much more efficiently when it's electronic health record. Errors are reduced greatly because of the terrible burden of just such uneven handwriting. You know, all of us thinking back to trying to read these scribbles that healthcare providers were putting into a chart, and the much greater risk of errors when they were handwritten like that, hand scribbled, and then just, you know, again, not so visible all the time, but the much greater ease with regulators who come in and look at a chart. So much easier when they're looking at electronic health record than thumbing through and trying to decipher people's handwriting in a chart. So back to this question of culture, it's really was putting out a vision of what I wanted us to be, and I really had a number of team members who shared that vision. Is that we all saw, and I believe healthcare providers, every user of this electronic health record, came to view that vision as being accurate and compelling, and something that they wanted to come join. Here at TaraVista, I'm told from staff members who had been here prior to its closing a year ago, some of them, you know, come and rejoin us, that they were all ready to go with 2 different systems that never got to the finish line for the providers here, and how frustrating that was, and how absolutely joyful they are about seeing that we're starting with this electronic health record right out of the gate, and they're all getting training on it in the 2 weeks now preceding our opening. These providers are ecstatic about starting with the state-of-the-art electronic health record.
It's great to have that enthusiasm as you're getting started, and all that support.
Very true. We have I said as we started, the irony is, or the, I don't know, the kind of synchrony here is that we have a whole training room that's set up a couple floors above us with 7 members of the Medsphere team who are out here training every nurse, mental health worker, physician, PA, APRN, etc. And the feedback has been just great from those folks, both about the actual tool, but I'd say even greater than that is just enthusiastic about, oh, we're finally moving into something that's more state of the art versus what they've been used to for 30 years. I mentioned before, absolutely needed a system that was able to connect with the pharmacy, connect also with the Pyxis and Omnicell, the 2 largest, there may be others, but automated pharmacy inventory and delivery systems. So this system has built those bridges already, able to have that integration. I mentioned labs before, being able to order labs right out of the chart and have them received back in. Other ancillaries, so somebody has to go to or have, we have imaging that can come into the hospital and have that captured within the chart. Really important to do. Each of the disciplines. So we have, I mentioned before that you have mental health workers who are in there charting. You have nurses who are charting on basic nursing care, but also, again, to that dispensing pharmacy. The physicians who are there. We're able to integrate the referral sources, send us an electronic fax, and we're able to upload those faxes of the initial presentation of patient right into the electronic health record, into their record, and have everybody who needs to see it be able to see that. The treatment plan, as you mentioned, we're actually in the midst now of co-creating with Medsphere a treatment plan that really suits the needs of behavioral health patients. So yes, you're right. I did look at, and some of the names, people can fill in names that are behavioral health space centric, as they describe themselves. And we reviewed them thoroughly, and they had interfaces that looked quite compelling, and were possible that they could have served our need. But the combination of the feedback that I received about them from places doing the installation, their cost, which was considerably greater than what CareView has proven to be. And the functionality just, at least at the time, wasn't there. And obviously, folks are aware that we chose easy choice. I didn't have to do any thinking about it, that we wanted to stay with our CareView platform and bring it out here to Mira Vista, this new hospital. We really didn't feel a need to entertain any other options. Yeah, it's a great question. The number of clicks. So what I'll hear is the language will be how many clicks I had to go through to get to sort of some spot in the record. And I can't speak to what it's like on the general med surge side. I'm just far removed from that these days. My focus is exclusively on behavioral health. But I would say that what's lost in that description is, I guess, a couple of things. First of all, these systems are evolving. You said with Medsphere, they are certainly evolving. They're working on this too, about what's the best workflow, what's the best way to have somebody navigate through this record. So it's improving. How it started many years ago is not the state of the art of where it is now. The other piece that I kind of come back to is that we always have to say compared to what. So compared to a paper chart, that what did it require? Well, it required you to be in the physical space of where that chart is. It many times required you to have somebody help find where a piece of data was, even though it's supposed to be logically oriented, organized in the chart. They aren't always. Labs haven't been filed yet. The pharmacy is still not in there yet. It's sitting in some other place, ready to be filed. So it's not electronic health record. It's much more dynamic. It's up to date immediately, all the time, in real time. A paper chart is never up to date in real time until you get to the point the patient is discharged and gone home, and now it's been collated within the medical records department. It always has pieces that are still waiting to be filed, and got to make sure you initial them. I've seen them, et cetera. So what's missing in that statement, including from providers I'm familiar with, is well, remember what you had to do when it was on paper. You had to go find it at somebody's office. It was in the social worker. They've got it. Oh no, you can't take it now because the doctor's got it right now. It would be, as we all are familiar, remember the carts that held the charts in them. That cart would be wheeled around, and you'd have a card in it marking that it was somewhere, and did somebody really record it almost like a librarian about where it is, whose office is it, et cetera. There are a lot of friction costs that exist with any paper chart that are become invisible once you now have an electronic chart. And so everybody's got to remember, it's compared to that, right? The other piece, which has been particularly helpful with COVID, this year of COVID that we've all had to suffer through, is that I just can't imagine how much greater of a burden it has been for places that are on a paper chart, because that every provider had to be inside the hospital to view it. And now a provider could do orders from home. They could be sitting in offices on their own and not with other care providers at that moment. You can do it over a Zoom meeting. It could be all sorts of collaboration where people can all be inside that chart at the same time. That's just impossible within a paper chart. So that time drain, that effort I doubt that our clinicians certainly don't leave their day any later because of an electronic health record, and I would argue they leave earlier. They are much more efficient now than it's possible to be when they were on paper.
It's hard to avoid that selective memory when you're dealing with frustrations of the now.
Yeah, yeah.
The then always seems a little bit better.
Yeah, but I come back to saying I am not aware of I mean, I haven't polled them recently, but I'm not aware of providers that would argue that they really would want to go back to that paper and pencil.
Right.
I just don't. Once they've made the conversion, it's hard to imagine they'd say, oh, I would argue for going backwards.
Right.
It's absolutely right. And again, hard for me to know all of the differences, but I'd say one of the differences is just how much care coordination, and I'll say it, kind of analysis and treatment of the patient, both while they're an inpatient. So there's that piece, OT, group members, group leaders who are entering, reviewing and treatment plan and entering their own information to the chart. Capacity, by the way, for those group leaders to do that efficiently. They've got 12 people in a group. How do you get a quick note in that really captures something important? Again, much tougher with the paper chart if that's what we're comparing it to. The treatment plan itself, to have a treatment plan that then each of these providers can continue to weigh in with how is this patient doing against any one of the particulars. I don't know how much, again, on the general medicine is itself such a wide range from surgery to other kinds of treatments. I don't really have a handle on what the differences might be compared to us. But certainly a piece is that we really need a capacity too for narrative of psychological and emotional pieces around a patient, right? Their family members, the report from a brother, a sister. If those exist, or the extent those exist within general medicine, it would seem they're quite different than the more psychological and emotional inputs that are going in for a patient that we're taking care of. But we also just have to remember we treat with medicines that are not, that part is not unlike what a general hospital is like in terms of pharmacological interventions that are going on with patients as treatments. We don't do ECT, but other places that do ECT, it's an intervention that is really a medical intervention as opposed to a psychological intervention. And so there's sort of those pieces. And then just at the discharge level, probably in parallel, but we discharge to another level of care always. There are no exceptions to that. And we need a way, which we do, that we have each of our patients leave with a discharge plan in hand. As they're discharged, they leave with that in hand. We don't have to wait to mail it out or do anything else. We're able to produce it instantaneously, have the key provider's nurse who's doing a nursing note on discharge, and the doctor and APRN doing a discharge note on discharge. Able to have that right there, here are the medications that you're on, and have patients leave the door with that in hand. Again, I come back to, I don't know what the comparison is on the general med surg, but I certainly know much tougher to do that if we're on paper and pencil. That's absolutely right, and a piece that if we think about what the evolution will be of this care and of the electronic or IT support, let's talk, IT support of that care. What I know we do not do, it's not built to my knowledge sort of sufficiently well, but will be, and that is this whole issue of once discharged from our care. Exactly right. How do you have platforms where you have the PCP weighing in and a social worker weighing in and even family members who are now sort of weighing in about a patient. And also, just say for our patients, recidivism is just about always avoidable. We have a high recidivism rate within inpatient care. And what does it have to do with? It has to do with folks having the social supports to continue with their outpatient plan. whether that's on the substance abuse side
Mhm.
to make certain that there's a glue that sticks them, that has them stick with whatever post inpatient care they've arranged to take part in. Um, uh, and it can be as simple as making certain that the script that was written, it was certainly written by the doc, did it get filled? If it got filled, was it taken? Right? Did somebody stay on those
Right.
meds? Because each stage of that, prescriptions that are written, as you know, the literature says many of them never get filled, and then they can get filled, and many of them don't continue to be taken. And while it's not the only determinant of whether somebody is readmitted, is certainly one of the determinants on the psychiatric side, on the mental health side. And then, of course, on the substance abuse side, it's really inpatient stay is always a start to become detox, get detox, to have a treatment plan that's going to carry someone forward. And it's really how does that care continue when somebody's an outpatient? How do they have social supports and other supports to make sure that they have aids to stay sober or to stay on a medication assisted therapy if that's the course that they're pursuing. But
Yeah,
you're
that really is the
of a team sport, so is exactly right. It's really many hands are responsible for helping all of us with our mental health and emotional health.
yeah. That does seem like what happens after the treatment often seems like the linchpin of success.
Absolutely true. Just about all of our readmissions, in my view, are avoidable. It's not the same as perhaps an infection following a surgery that you take all these precautions but can still happen, or some other turn of events with certain medical maladies. I feel like if we had better outpatient systems that continue to hold these treatment plans in place, our readmissions would be reduced dramatically.
Right.
Yeah, so it's like, as I said, when I was looking at what are the requirements of getting system, they had to already have a seamless introduction or seamless integration of the revenue cycle side and the accounting. So which Medsphere's products do have. So folks probably know, but if not, just lay out that for the very first call for admission, we're able to gather information about a potential admission. Once we make the decision to admit, able to have the name and demographics and insurance information loaded into the system. In our state, I assume many states of people listening in, we have managed care for just about everything, including what's traditionally called Medicaid. In our state, it's called Mass Health. We have MCOs, managed care organizations, that manage those the benefits for those payers. So it means that for nearly all, not all, but nearly all payers, Medicare is an exception, there's a prior authorization requirement that's satisfied when patients are in an emergency room that verifies they need inpatient level of care. There's an authorization process that happens. There's a number attached to that. By having electronic revenue cycle product that again integrates with our medical record, we're able to gather all of this information one time. It's loaded in there once. It then gets transferred into each of the components of this, of revenue cycle, healthcare record, and ultimately accounting, to be able to track that. And as everybody on this viewing this today knows, it's really days in receivables matter. How do you cut the time between the patient's discharged and they get coded, the record gets coded, it's sent out to one of the clearinghouses, it goes to the insurer, and the revenue comes back into the system. We have run that a very low number of days, and we do it because we're enabled by these systems. We leave very little money on the table because of a tight system of having prior authorization and then any subsequent authorizations, so that we have very few days of care are uncovered in some way by their insurance plan. And then back to the accounting side, we really want to know what is our true receivable, not gross charges, which are of just about no value whatsoever, but what is the actual receivable that's sitting out there, and how are we doing by each insurer in terms of the payments that we expected and the payments we actually received. So as a hospital CEO and as founder of a hospital that's a for-profit, it'd be either for-profit or not for-profit, both would be similar, I'm sure. But we have to make certain that we're being paid appropriately for the care we provide, and
yeah.
we've chosen has satisfied that.
What do you see in the future?
Yeah, so I guess I'll answer that question in kind of two directions. One direction is kind of outward, and that is that starting one hospital was a totally improbable event. I say at our initial orientation with employees, 1 in 10,000, 1 in 20 or 30,000. Very improbable that I would ever start a hospital. Just not that many get started, and when they do, they're usually very larger groups. So it was a very improbable event, to say the least. To have a second one happen, I don't know how you sort of rank that in terms of probabilities. It was a bit of a surprise. We certainly had an eye to the outside world about whether there'd be any opportunities, but this one presented itself very surprisingly. It really kind of came out of nowhere. I will say, having done two, the idea of pursuing others is now not far-fetched at all. So we're building a platform now, and Medsphere is a partner in that. In terms of this will be the system that we implement wherever we go, if we're so fortunate as to have any other opportunities. So that's kind of the outward, the business side of it. But the other piece I'd say about electronic health records in general, it's really not specific to Medsphere at all, is that they're still designed to capture a great deal of regulatory and billing and those sort of needs. And I'd love, as all clinicians would like to see, is that a greater use of these for clinical research and knowledge about efficacy of medicines, of a given treatment plan, et cetera, that it that it's able to be mined for the real promise that electronic health records hold, that it is an absolute requirement to understanding population health, understanding what interventions are more successful than other interventions. And it's a really general observation as opposed to Medsphere or NetSmart or Meditech or any of the other platforms. They are equally, in my view, have not realized the full promise of what these systems can yield as time goes on, to understand population health and as I say, the best interventions. What's the efficacy? It's only relational databases that have any possibility of being able to unearth what are interactions of high blood pressure and this medication or other diagnoses. It's the robustness of a computerized system, of an IT system, that lets that get unpacked, and we just haven't yet seen anything like the promise of what that can be in my view. Let's see. So if I answer the question with electronic health record, if I use that lens, it's gone very smoothly. So I'd say I really have not had negative surprises about that. We had a good, I guess, view of what it would be like, and that view has been pretty accurate. Starting hospitals, that's a different question. They are. It's just quite a task. I say to folks, I don't know, there's been some press that's quoted, there are thousands of items that go into starting a hospital. They're not always obvious when you're in a hospital. They're just there. You just take it for granted. And then when you start from scratch, you've got to make sure that the smallest detail, you've got a main telephone number. Can you call all the extensions? Is that working? Does the Wi-Fi system work? Does the kitchen have enough food? A lab, a pharmacy? I mean, there's so many items that now become very visible and explicit because you have to have thought about every one of them. And it's fun, it's exciting, but a lot of sleepless nights too, I have to tell you.
That's understandable. If it's gone smoothly at all, it's at least due to your probably the mountains of planning that you did in advance. Dr. Krupa, we'll let you get back to your go live. Thank you very much for giving us an hour of your time today, an hour plus with preparations. We really appreciate it. It's been nice to talk to you. Thanks very much.
My pleasure. Really enjoyable to do. I love being able to have the chance to tell some about our story, and I hope it's helpful to those who tuned in.